So talking about hypertension, dusting off the patho for hypertension, the first thing we want to kind of get refamiliarize ourselves with from patho is primary versus secondary hypertension. Primary being like essential idiopathic type of reasons. So these are like the genetic or environmental factor kind of things that people may be exposed to. Secondary hypertension is the one that's most likely kind of derived from heart disease and other cardiac dysfunctions. So really it's more a problem of like raised peripheral vascular resistance. So this can be things like atherosclerosis. That's the best time I've ever said it. Or like cardiac output alterations. And then the final one is emergent hypertension. So this is like hypertensive crisis. So these are patients with blood pressures in the neighborhood of like 200 over 100, where we really do need to get their blood pressure down right away to prevent them from having complications of these very, very high blood pressures. So when we look at assessing a patient with hypertension, recognizing cues is really difficult for hypertensive patients, especially like urgent or chronic hypertension patients in that yellow zone between 120 over 80 up to 200 over 100. So there's a big range of hypertension that is really most often asymptomatic. We do know when we look at risk factors and screening for patients that increased age means increased risk for hypertension. Just because the longer people are alive, the more likely they are to have hardening of their arteries and plaque buildups over time. So the atherosclerosis is more likely to develop. So increased age, higher incidence of hypertension. For analyzing cues, when we look at the specific symptoms that we want to start linking to see if a patient is or highly suspicious for hypertension, it's really difficult to do because there isn't like a go-to body system that's really affected or a go-to symptom presentation or syndrome that we're really looking for. Most of the time, patients complain of just something not feeling right, like their body just doesn't feel right. Patients can complain of visual changes. So things like bouncing vision, which is kind of like when you get super angry and it's like the vision starts kind of tremoring and bouncing around a little bit, that kind of thing, or even diplopia, so like double vision, so their eyes aren't able to focus properly. Headaches are also a big symptom that we look for when, as a secondary data point when assessing for hypertension. So patients can start to develop like these crushing headaches that often occur when they're in that range of like severe or emergent hypertension. So usually we see headaches as a late symptom for very, very high blood pressures. If you ever have a patient with a headache and hypertension, like this is a concerning finding because that's already two pieces of evidence about the same thing. We've got the blood pressure reading and a headache. So we're already kind of like working our way up to that 3 levels of evidence. For prioritizing hypotheses, on the medical side, we're looking to diagnose patients. Not we, but the physicians are looking to diagnose patients with a problem. The easiest way this is done is through screening. We do blood pressure screenings. As nurses, we do the blood pressure screenings. We check patients' blood pressures in like primary care offices. We check them in urgent care clinics. Anytime we encounter patients, we check them. Even like dentist office, they check blood pressures, things like that. It's also a key part of health screening events. So like the 9 News health fairs, things like that. Checking vital signs is often the first station that patients go through before they have blood draw, before they meet with a nutritionist, anything like that. It's really important for us to know as nurses that we should not be causing panic in patients. So if we get a high blood pressure reading, that's not a diagnosis. There is a thing, white coat syndrome, which applies not just to people who wear white coats, so like doctors, but also to nurses. People get nervous when they encounter the medical system. So we do want to counsel them that just because they have one high blood pressure reading when we check vitals, that doesn't mean they have hypertension. The way to get a diagnosis for hypertension is that we're going to have them record their blood pressures over a period of time. So we need to see multiple occurrences of high blood pressures in order to achieve that hypertension status. So patients will be followed and kind of tracked for a little while before we diagnose them with hypertension or start doing, or before physicians, here's a better way to say it, before physicians are looking at really prescribing antihypertensive medications to patients. There is no imaging or sampling associated with hypertension. So really it's all about screening, checking patients' blood pressures over a period of time. On the nursing side, we have a lot of things we do with hypertension. So some of the hypotheses we start to prioritize is around knowledge deficit. Like first, do they even recognize that they have a potential chronic illness? So we need to first evaluate that, look for family histories, things like that. So start doing some of that kind of deep diving and interviewing, review of systems kind of interviewing that you guys learned in health assessment, where you ask all the questions about family history, medical history, things like that. And also we want to let patients know that this isn't the kind of thing that they want to just kind of ignore and hope it gets better over time, because there can be some very real secondary organ damage that can occur with untreated hypertension. And we'll get into that in just a bit. For risk management side, there is a risk of vascular trauma with these patients. One of the big complications of acute or emergent hypertension is that they can actually the pressure in their cerebral arteries is actually so high that they can rupture, causing a stroke. So that'd be really, really bad. And that's one of those complications people can be exposed to if they don't seek treatment for their high blood pressures, especially very, very high blood pressures. For the solutions we want to start generating with these folks, so kind of setting goals and looking at how are we going to make them better. One of the first things we want to do is prevention. So people with a strong family history of hypertension, we want to help them to prevent developing high blood pressures themselves. One of the fastest ways, or one of the first interventions we tend to do, is diet modification. So these patients are going to be on, kind of skipping down to the middle of the slide now, they're going to be on cardiac diets, which are like low salt, low cholesterol type diets, which is going to help with that increased risk with aging because of the hardening of the arteries, the plaque buildups. The other thing we're going to do is teach them about like DASH diets, which is a dietary approach to stop hypertension. These are diets that are not just restrictive, but also prescriptive. So like a cardiac diet is restrictive, like don't have salt, don't have high fat foods, don't have a lot of processed foods, things like that. It just tells people what not to eat. The DASH diet does that, but it also helps to give them ideas on what they can eat. So it really does prioritize things like fruits and vegetables. So it helps to show people what they can have rather than just what they can't have. So there is going to be the low salt, so salt substitutions, low fat. So we want to avoid red meats, highly processed foods as well, just like we do with our cardiac diet. But then also adding in, like we want to encourage you to have more servings of fruits and vegetables per day, more whole grains, things like that. Next thing, going back up to prevention, is increasing activity. So back to the top bullet point. So patients who are at risk for hypertension, we want to encourage them to start participating in activity programs. So moderate exercise routinely, because we do want to alter their cholesterol levels. You know, it's HDLs and LDLs, with HDLs being the good cholesterol and LDLs being your bad cholesterol. We want to flip that ratio so patients have lower LDL counts and higher HDL counts, because that'll help with their atherosclerosis buildup and over time. The other big prevention thing is we want to increase the risk of other really serious complications associated with untreated hypertension. So we talked about patients being at risk for stroke because of the increased pressure in the cerebral arteries. Other things, other arterial pressures that can be at risk are like heart attacks, so myocardial infarctions, and also acute renal failure leading to chronic renal failure. Untreated hypertension is the #1 national cause of chronic renal failure requiring dialysis. So that's definitely something that we don't want to threaten our patients with this information, but we do want to make sure they're aware of it. And then moving down to the bottom bullet point, severity. So how severe is their hypertension? Always something we need to kind of look at when we talk about planning care for these patients. If their blood pressure is high, so it's like in that yellow zone, between 120/80 to 200/100, these are people who should probably go see a doctor, you know, because this is a little bit more than just like white coat syndrome usually. They probably should be checking their blood pressure every day and see a doctor as soon as they can. But we want to recommend like outpatient follow-up for these patients, especially if they have no other symptoms. Because again, we don't have a compelling case. We don't have 3 pieces of data to say like, oh yeah, this person was in bad way. For emergent hypertension, so that very, very high, like 200 over 100 and above type hypertension, that's really kind of a different ballgame. That's when we do want to start recommending that patients go to an urgent care clinic, go to one of those freestanding ERs, go to an actual emergency room associated with a hospital, because these patients really do need intervention before they start to really increase their risk for stroke or heart attack. So that's kind of our big cutoff, is like 200 over 100. Less than that, see a doctor as soon as you can, but call them today to make an appointment. Higher than 200 over 100, it's like you should really like cancel your plans for the afternoon and make other plans that involve having a doctor and the healthcare system in your future. So that's really our cutoff for generating solutions. The actions we want to take. There's a ton of independent interventions that we are going to do in the nurse world for patients with hypertension. So we talked about the dietary stuff, diet modification. So cardiac versus DASH diets, those diet for the hypertension diets. The dietary approaches to stop hypertension. We want to teach them about the components of that and also to prioritize fruits and vegetables as a part of that diet. Activity. So we want to help them to identify an activity program that's going to be realistic for them. And we're not talking about like, oh yeah, you got to go join a CrossFit gym. You got to like show up 4 times a day, get on the leaderboard, all that kind of stuff. Like that's not realistic for a lot of people. So we do want to talk to them about realistic solutions for activity. So things like walking 2 or 3 days a week, walking around their block, going to a park nearby their house. Things like that, not just like, yes, you need to like get on the bandwagon to train for a triathlon kind of thing. Also, home vital signs assessments. How can they check their blood pressure at home? There's a lot of really cost-effective and easily accessible types of blood pressure monitoring devices that patients can use. So there's the blood pressure cuffs at like pharmacies, like a Walgreens or a grocery store pharmacy, that they can stick their arm in, check their blood pressure, and track those results. They can also, if they have financial resources available, there's lots of home blood pressure units that can be purchased very, very reasonably, and then they can track their blood pressures over time. And then also we want to educate patients as to when they should be seeking additional healthcare. So teaching them about, here's some signs and symptoms that you should look out for if you start to experience those visual changes or get headaches and you check your blood pressure and it's also high, probably a good time to start thinking about going to an urgent care clinic or kind of going to the hospital. Then secondary risk assessments. So making sure they know what the complications are associated with uncontrolled hypertension. And I also like to encourage families to be a part of this education, because most of the time patients don't recognize signs and symptoms of stroke or heart attack in themselves. Often other people recognize that in them. So I want to include the family in this as well. So teaching patients about unilateral deficit for stroke, heart attack, so chest pain, shortness of breath, renal failure, like they stop making urine, or disproportionate urine to what they're drinking, or they start to have like swelling in their legs, things like that. For dependent interventions, there are a ton of medications that get prescribed to control hypertension, and a lot of them are based around the etiology of the hypertension. So thank goodness there's physicians that go to a lot of school to learn what antihypertensive patients should be on, because they are very good at prescribing antihypertensives to patients, which is wonderful. The thing I need to pay attention to is the education about those medications. So what kind of side effects should they expect? Now, anytime we're giving a drug for a physiologic problem, we want to make sure we don't overdose patients. So managing for hypotension, because patients can have like objective hypotension and subjective hypotension. Objective hypotension is when their blood pressure actually gets low. So they become symptomatic, their blood pressure is low. Subjective hypotension is when we take them from like high blood pressures, like 180s over 90s kind of thing, and bring them back to 120 over 80, so they have normal blood pressure. But because their body has adjusted to that high level of blood pressure through baroreceptors in their body, when we take them back down to normal, they feel hypotensive. So they can get symptoms of like dizziness, orthostasis, activity intolerance, those kinds of things. So we do want to help them to recognize those symptoms, and they don't necessarily need to seek care, but they do need to be careful that they don't fall down and then need to seek care. But let them know that over time, those symptoms are going to resolve as their body readjusts to having a normal blood pressure. And then the frequency of taking medications. It's not easy for anybody to incorporate a medication regimen into their daily lives. So really working with patients to figure out what their home routines are and how we can work with those routines to get their blood pressure medications kind of managed, super important. So meet patients where they are and incorporate those into their regular activities. So for the evaluation component, first and foremost, by the numbers, check their blood pressure. Should be closer to that normal range than it was before. Things we want to look out for are those rebound headaches. So those symptoms of hypotension that are subjective. So normotensive, but because people have been hypertensive for so long, they're now symptomatic of hypotension, even though they're not actually hypotensive. So we do want to make patients aware that they may experience those symptoms when they start antihypertensive therapy. Eventually, we do want to resolve those symptoms, and they will resolve over time, but patients do need to continue taking their antihypertensives to keep their blood pressure low so that their baroreceptors can kind of recalibrate to a normal blood pressure. For education, we always want to make sure patients can teach back. So teach back about the risk factors, teach back about how to take their medications, what blood pressures are concerning, where they should seek care. Demonstration, anytime we can see patients performing the behaviors, that's always best. So patients that we start therapy on, we want to see them kind of go doing that orthostasis kind of behavior. So going from laying down to sitting up and just kind of sitting on the edge of the bed for a minute, make sure they're not getting dizzy, lightheaded, that kind of feeling before they start walking around. And then have them verbalize like a medication plan. Like, when do you plan to take your medications twice a day? In the hospital, it's like 9 a.m., 9 p.m. It's pretty rigid, but hardly anybody takes their medications at 9 a.m. or 9 p.m. or both. So what is their unique plan for taking these medications? And then we want to be assessing for signs and symptoms of the complicating things. So strokes, heart attacks, kidney failure while they're in a hospital. So we'll be checking labs, we'll be checking vital signs, and we'll be assessing for those specific symptoms like the unilateral muscle weakness or chest pain. So the stuff we talked about, the pro tips for hypertension, most of this management is outpatient unless it's emergent. So screening is really, really important. We also want to be screening for that other organ involvement. So strokes, heart attacks, kidney function, those are all part of the stuff that we want to be on the lookout for, even in the outpatient setting, to make sure that our patients aren't experiencing some of those secondary complications of uncontrolled hypertension. Management of this is multidisciplinary. So there's the medication side that physicians are going to help us to manage, but we're going to need to track what the response is to those medications for patients, and also lifestyle modification. So activity, diet, exercise, that kind of stuff. Early assessment, this is kind of a thing because most people don't recognize, they don't have symptoms that they have hypertension. So screening for hypertension is a routine part of people encountering the healthcare system. So we need to make sure we're doing that, especially if we're encountering people of advanced age, so we can identify hypertension as quickly as possible, minimize some of the risk of those secondary organ involvement stuff. And always, always, always be on the lookout for emergent hypertension, because that's when all the bad stuff happens. And we want to encourage people to go to the emergency room if your blood pressure is over 200 over 100. That's what we got with hypertension. Next, we're going to talk about heart failure.